Good morning, good afternoon, or good evening, depending on where you are. I would first like to thank the organizer of this meeting to give me an opportunity to present the experience of the African Society for Laboratory Medicine in scaling up laboratory services to achieve the 95-95-95. I declare no conflict of interest. So this presentation is going to focus especially on viral load. I acknowledge that there are other testing that are important for the 95-95-95, but viral load is really an interesting case study and is specifically a key to the third 95. And if we go back a little bit in history, we will see that the WHO guideline for antiretroviral treatment in 2013 recommended to use the viral load as a preferred method instead of the CD4 count to monitor the treatment effectiveness. Then in 2016, the guidelines recommended that all HIV positive persons should receive the treatment, and the UNAIDS fast track targets, number 3, recommends that 95% of the patients receiving treatment should be virally suppressed by 2030. So due to this recommendation and the target of the UNAIDS, there's been a sharp increase in the number of people in receiving treatment in Africa, a 200% increase from 2010 to 2018. And there's an implication on the number of viral load tests to be delivered to this additional number of persons. An interesting fact about the viral load is also that it is a testing that is often used as a gateway to differentiated service delivery by allowing the triage of patients, which would be differentiated between the stable patient with suppressed viral load that can then be referred to less intensive care at community level, and unstable patient with high viral load that need to be referred to intensified adherence support, advanced disease testing, for example, and clinical packages for to manage comorbidities. And that's important to avoid the overload of the HIV care services. So what is the progress of the viral load scale up? And I'm showing you the case of 7 PEPFAR supported countries. And these are results that have been published at Dr. Lecker for the US CDC in 2021. So PEPFAR worked and shows the result of those 7 countries that you see on the left, and they compare the number of patients before the scale up with 2018, when the scale up of viral load was really well on the way. And we see a sharp increase in the number of patients that are receiving treatment in those 7 countries, between 50% for Lesotho and 70% for Namibia. And now the question is, can the viral load really take up to manage all of these additional patients? This figure is also from the same research and shows you a representation of the increase in the percentage of patients with at least 1 viral load per year. And we see that in the 7 countries, the viral load has really increased very sharply, which means that it catches up with the need to address the additional testing needs. So, however, behind these success stories, there are still some few gaps. And you see 2 figures that are being extracted from the UNAIDS report of 2020. And you see the percentage of people living with HIV who are virally suppressed, taking the denominator of every patient that know their HIV status. And we see that in Eastern and Southern Africa, 65% of all the HIV people knowing their status are virally suppressed, with 45% in West and Central Africa. It's lower, with some worrisome result, especially within men as compared to women. And so that really illustrates several problems. So the linkage to care might be an issue. Is everyone that knows the HIV status receiving the treatment? Is everyone on treatment receiving a viral load? And is everyone receiving a viral load virally suppressed? And these are the problems that come through the numbers that we see here. So if we examine the viral load testing cascade, and this is a slide that has been shared by Dr. Trevor Peter from the Clinton Health Access Initiative. And what the Clinton Foundation has done is that they have broken down the HIV viral load testing cascades in different steps from the moment when the patient comes to visit the facility, the collection of the samples, the transport, the test performed, all the way to the clinical action when the result is known. And you see the first result down with the red percentage, and they look at what is the percentage of patients that are lost along the way. And they see that for viral load, 14% of the patients are lost, from the moment a patient comes to visit the facility and the sample collection. And then we see that in the later steps, there are very little information available to actually understand what is the itinerary of those patients. And it really touches upon the lack of monitoring system for viral load. When we look at the results down for early infant diagnostic, we see a dramatic loss of patients at the first stage of the viral load testing cascade, and we really don't have a clue what happens for the clinical action for these infants that are being tested. So still looking at those at this viral load testing cascades broken down into different steps. What are the system issues that can affect the viral load at all these different steps? So we see the system that are underlying each and every step of the cascade, and we see the policy and regulation in the early steps, the sample referral system, quality management system, especially when we perform the test in the facility, the supply chain for the reagent, the laboratory clinical interface, and of course the workforce, which are all very important for a good utilization of the results. And there are a lot of weaknesses in those systems that are going to have some implication. And in the first steps of the viral load testing cascade, we can see that there's a poor demand of the viral load from both the patient and the clinician. In the facility, there are lack of SOPs to really do a reliable testing. There are issues with the sample referral system, poorly optimized work, lack of compliance to the guideline. A lot of issues are coming, which explain that the viral load testing is not optimal everywhere. So in order to scale up the viral load testing, it takes a combination of technical and non-technical solution at facility and system level. And I would like to share with you some of those interventions that has been successful. So the first one is about the sample referral and the establishment of hub and spokes sample referral to improve access to centralized viral load testing. We know that capacity is very scarce in many settings of Africa, and it's a problem of sharing or accessing this capacity wherever a patient might be located. So this is like a representation of what a sample referral can be, and a lot of models for sample referral have been summarized by Dr. Fujungo and colleagues from the CDC in 2017. And here we see a system that is a centralized sample referral, whereas a central laboratory is going to take care of the viral load and other sophisticated molecular testing. And the samples coming from the periphery, which are the spokes with lower capacity, such as microscopy, basic rapid tests, the specimen and not the patients are then going to be gathered to hubs that have intermediate capacity, and where tests like the CD4 count or test on the gene expert can be done. And then finally, the tests that really require molecular testing go to the central laboratory. And the advantage is really that then you can also centralize the supporting system, such as the quality assurance, the supply chain and the supervision, to a central place and not overstretch the capacity across the network. So this kind of model has been implemented in Uganda already for a while, with collaboration from different partners like the CDC and the USAID. And through the GIS mapping of the facility and the capacity across the country, Uganda has been implementing a sample referral whereby a hub of capacity is serving a radius of spokes within 30 to 40 kilometers. And by establishing 100 hubs, Uganda is capable of reaching out to 2,500 health facilities, and they achieve a 90% coverage of the testing needs for the HIV viral load. And the sample is transported through motorbikes, and a rider reaches 20 to 30 facilities that are under the catchment area of the hubs at least once a week. And they do the sample pickup, and they also do the drop-off of the results. Point of care testing is also a popular and effective way to simplify the viral load testing cascade. And why is that? It's because it collapses a lot of the different steps of the viral load testing cascade into a single visit of the patient. And that has the potential to eliminate all the loss points between the sample collection, the test performed, and the result return, because the results can be provided on the spot. And then the result return and the clinical action can also be done in a single visit. And there's a lot of technology that can support a point of care for viral load, but also for the CD4 count. So there've been a lot of evidence showing the benefit of the point of care technology in terms of increasing the percentages of patients that can start ART immediately after their viral load, and also the percentage of results that return that are used within the 60 days. But introducing new point of care technology can be lengthy, and we know what are the usual caveats for the uptake of this technology by the countries. There are unclear regulatory pathways. There's a lot of evaluation that can take care in the country before the product is allowed to be used. There's a lack of normative guidance in the sense that it's sometimes difficult for the country to use a point of care in a clinical setting as opposed to a laboratory environment. There are high prices, and there used to be a lack of long-term funding commitment from PEPFAR and the Global Fund, although this evolved since the past few years. So the Clinton Foundation, and they shared that slide with me, really gave a lot of guidance and orientation for the stakeholders and implementing partner on what kind of work stream do we need to conduct in order to accelerate the approval of point of care testing, make sure that it is established routinely within the clinical or laboratory activities. They've also strengthened the right system, the workforce, the supply chain. They have supporting global access pricing, catalytic procurement, and co-investments by global funders. There's also an interesting entry point to improve the scale-up of viral load, which is integrating the viral load testing on existing instrument and platform. And a lot of solutions have been collected through consultation with stakeholders and partners that have been convened by the WHO in collaboration with ASLM. And you see on this table the different platforms which have a large footprint on the African continent. And you see on the left all the different diseases that in theory those platforms can actually address. And they can address HIV, early infant diagnostic, hepatitis, multi-resistance tuberculosis, and HPV. So in theory, it's very attractive to think that those molecular platforms can be used to multitest so that we don't need to buy multiple instruments for the testing. So there's been some piloting of integration, and it's a different level of advancement in different countries. And what we can see is that the GeneXpert is a good candidate for integration because usually there's been a lower rate of utilization of the gene experts that are available through the TB programs. But however, there are sometimes fears about the TB program, whether or not including HIV would cannibalize the instrument and not be beneficial for the TB program. But in reality, the pilot demonstrate that when HIV and TB are integrated, there are no negative impact on the tuberculosis testing. There is a decrease of turnaround time, not an increase, sorry about that. And also the programmatic cost, they can be really a benefit in sharing the cost through the same instrument. And there's a good acceptability of the people that use the same instrument to do the testing. There are challenges on the ground. We need to adapt the workflow in the laboratory, sometimes organize shifts, also update the workforce capacity for the increased flow of patients and sample. It's a new technology. We have to prevent the overuse of equipment and of course respect the tier-specific recommended testing package when we recommend integration. How do we make integration work? And something that is very useful is to select the sites where integration or new instruments are going to be placed. And that's to ensure there's a maximum coverage of testing need and a maximum efficiencies. So this really, all these interventions are summarized under what we call diagnostic network optimization. And that's basically working on GIS information or where the facility, the instrument and the capacity is located in a country. And ASLM and the Africa CDC have such a program that is called LabMap, where we triangulate this GIS information with information on the population density in a country and the road network to make sure that the best decisions are taken. An example of this kind of data is shown here on the right, where we see all the laboratory facilities and in Burkina Faso that are overlaid with population density. That's what you see in green. The facilities are the red dots. And behind that, we also have the road network. And you can calculate where integration or where implementing new capacity is most cost effective. We have our colleague from FINE that also have a similar system that's called OptiDX that focuses more on technology and that takes also sample throughput into consideration when they simulate where is the best place to conduct integration. And I put here for your attention a publication where you can read more about diagnostic network optimization. Another interesting intervention are viral load campaigns to increase the demand for viral load testing. And we collaborate with the International Treatment Preparedness Coalition from South Africa, ITPC. They have an activist toolkit because it's of course important that the civil society and the patient can demand for their viral load so that you increase the demand and the testing. So here you see where ITPC trains the country team to prepare their campaign. These are some of the results of those campaigns. In Kenya, they had chosen for a hashtag campaign where they target the young population to demand to know their viral load. Here in the Democratic Republic of Congo, they also target the young population, the pregnant women, and also they do the campaign in local language. In Zimbabwe, they chose to have some material to know about the viral load that targets different key population, and they have really used social media and the radio to propagate their campaign, and that's really very important. There are other interventions really improving the return of results to clinician and patient through SMS. That's, for example, done in South Africa, Zambia, and Kenya, and it's partnership with the telephone company that has to send the SMS. There is the designation of champions at facility level. They can ensure the quick transfer of available results to the patient file, and the US CDC has nice framework and guidelines to implement that in the clinic. And something that is not typically thought about as an intervention is to manage the additional toxic waste that is related to the increased viral load testing. And that's implementing tools to estimate the amount of waste, increase access to incinerator, avoid that toxic waste is being dropped in the drain, and update the policies for biosafety with really nice examples from South Africa. So sharing good ideas and best practices, they exist for HIV care. And so how can we do that to accelerate the scale up of the viral load? Some countries we know have found better ideas in several areas to scale up the viral load testing. And we need to find a way to share those best practices, innovation, and implementation solution from one country to the others. So at ASLM, we have what we call the Laboratory System Strengthening Community of Practice. That's the LabCOP. And we work in all the countries highlighted in yellow on these slides. And what we do is we have participants that are country teams, that are a mix of stakeholders and discipline, to take different perspectives into account when we scale up the viral load. So these are people from the laboratory sector, policymakers, clinicians, civil society, implementing partners. And what we do is that we have those country teams that have interactive seminars online to share their experience. And we also help those countries with individualized country visits to discuss about the result and to really provide hands-on technical assistance. And we focus the area on what are really the priority for funding opportunities. So this is how, one of our echo session, online session looks like, with several people connecting, typically 100 to 300 people for each connection. And you see in the figure down there, we've done since the last 2 years, more than 40 sessions with 20,000 different connections, also spilling over Africa, especially because this model was very popular also to answer questions on the COVID-19. We had a lot of topics that have been addressed, as you see in the list, from result utilization, demand creation, return of results, and funding, which is really a topic that is rarely addressed. And we have a lot of different contributors from different horizons. So, and if you visit the website of the ASLM, you can find those presentations and the products of the discussion. So what does ASLM do within the LabCOP? We summarize the best practices and the discussion into what we call recipes on several topics that the country teams can use as really practical guidance. And what we try to do here is to offer the country not a menu, but how they can cook, let's say, a chocolate cake, if I would use that metaphor, so that they can really become very confident and implement solutions that are tailored to their specific context. What we do as well within the LabCOP is that we measure the gaps and the strength and the progress along the viral load testing cascade in the different countries. We use standardized tools, and what you see on the dashboard at the bottom is the different steps of the viral load testing cascade. Where are the gaps, and you see the red and the yellow colors is where most of the gaps are. And what we do with those results is that every year the data feeds into action plans that are targeted to those gaps, and we submit those funding, the countries submit those fundings to the PEPFAR and the Global Fund. And like that, we have really an evidence-based intervention that can produce results. So what are the take-home messages? So improving access to and utilization of viral load results is very important, and that goes beyond the laboratories. It should be thought in terms of network, interfaces, and systems. Systems strengthening intervention are key to the acceleration of the viral load scale-up. Many good practices exist across Africa, and they need to be shared to really accelerate the scale-up of the viral load. And all those lessons learned for the viral load are applicable for other testings that are relevant to the HIV program. And finally, very important, there has to be an alignment of the objective from the HIV program, the funding, and the national policies in order to have the best results. So this is my last slide. Thank you so much for your attention. And please, if you can, join us for the upcoming ASLM conference in 2021. Thank you.